Hello, my name is João Madureira and I'm a neuroradiologist at Hospital Santa Maria Lisbon and a former fellow at NeuroIBCETR. In this series of videos, we will cover the main topics regarding radial access neurointerventions and how this fits the overall history of ENR. In this section, we will review the main challenges and complications of endovascular procedures through the radial access and give some tips on how to solve them. So transradial complications can be divided in intraprocedural and post-procedural, and then divided in bleeding or non-bleeding events. Among these, the most feared are spasm, material kinks, and radial artery occlusion. Radial artery occlusion was already mentioned in the previous sections and can be avoided by a careful puncture technique with echo guidance, antithrombotics, and smallest sheath possible. There are some predictors of spasm, some are modifiable and some are not. It's good to know which ones can be manipulated in order to reduce the risk of spasm. If spasm happens, there are several pharmacological and non-pharmacological techniques that can be tried. The most simple are repetition of the intra-arterial spasmolytics or subcutaneous nitroglycerin. If all of these less invasive techniques that you can see on this fluxogram fail, brachial plex block or deep sedation can be attempted to block the vasoconstrictive terminals and promote vasodilatation. As we said before, vascular tortuosity and loops can be a problem, and this is better, and it's better to know if they exist from the start of the procedure with an arm angiogram to avoid perforation. That can be done just after you insert your radial sheaths. And if a loop or tortuosity appears, you can try to apply external pressure to straighten the vessel, use microcatheterism or balloon-assisted tracking. Catheter kinks are other feared complications and can be avoided by carefully manipulating the material and avoid excessive rotation of the catheters, especially at the arch level due to extreme angulation. If that happens, try to untwist the knots in the opposite direction, apply external pressure, encase the loop or the knot with a large diameter catheter, or use a snare device. Regarding perforation, if you can go distal to it, continue the procedure. Since the vessels are small, the catheters inside the vessels will work as internal tamponade. If it's not possible to stop the procedure and use external compression, antegrade, balloon inflation, or protamine can be used. If an hematoma occurs, try to apply external pressure and carefully observe its evolution. Most of the times it stops, but if it continues to grow, the compressive surgery might be needed in large hematomas to avoid compartment syndrome. So these are the main complications and some tips that you can use to solve the problems and be more secure in your procedures. Thank you for your attention.